This is the audio lecture for Chapter 5, Infertility, Contraception, and Abortion. Infertility is a serious concern that affects quality of life of 10 to 15% of reproductive age couples. Commonly, infertility is considered to be a diagnosis for couples who have not achieved pregnancy after 1 year of regular unprotected intercourse when the woman is less than 35 years of age, or after 6 months when the woman is older than 35. For the couple experiencing infertility, diagnosis and treatment strategies require considerable physical, emotional, and financial investment over an extended period of time. Feelings connected with infertility are many and complex. Nurses who care for infertile couples should consider the following four goals. 1. Provide the couple with accurate information about human reproduction, infertility treatments, and prognosis for pregnancy. Dispel any myths or inaccuracies from friends or the mass media that the couple may believe to be true. 2. Help the couple and the healthcare team accurately identify and treat possible causes of infertility. 3. Provide emotional support. The couple may benefit from anticipatory guidance, counseling, and support group meetings, either face-to-face or online. And 4. Guide and educate those who fail to conceive biologically as a couple about other forms of treatments, such as in vitro fertilization, donor eggs or semen, surrogate motherhood, and adoption. Support the couple in their decisions regarding their future family. Factors associated with infertility. Although exact percentages vary somewhat with populations, approximately 80% of couples have an identifiable cause of infertility, with about 40% of these causes related to factors in the female partner, 40% related to factors in the male partners, and 20% related to factors in both partners. About 20% or more couples will experience unexplained or idiopathic causes of infertility. Unassisted human conception requires a normally developed reproductive tract in both the male and female partners. For ovulation to occur, both partners must have normal, intact hypothalamic pituitary gonadal hormonal axis that support the formation of sperm in the male and ova in the female. Sperm can remain viable within a woman's reproductive tract for at least 3 days and for as long as 5 days. The oocyte or the egg can only be successfully fertilized for 12 to 24 hours after ovulation. Assessment of female infertility. Evaluation for infertility should be offered to couples who have failed to become pregnant after 1 year of regular intercourse or after 6 months if the woman is over 35. The basic infertility survey of the female involves evaluation of the cervix, the uterus, the tubes, and peritoneum, detection of ovulation, and hormone analysis. Timing and description of the common tests listed on this slide are presented in Table 5-1 of your textbook. In Box 5-1 of your textbook, Factors Affecting Fertility provides an in-depth look at all the possible causes of female infertility. Assessment of male infertility. The systematic investigation of infertility in the male patient begins with thorough history and physical examination. Assessment of the male patient proceeds in a manner similar to that of the female patient, starting with non-invasive tests. The basic test for male infertility is semen analysis. A complete semen analysis, which is the study of the effects of cervical mucus on sperm, forward motility and survival, and evaluation of the ability of the sperm to penetrate an ovum, provide basic information. Hormone analyses are done for testosterone, gonadotropin, FSH, and luteinizing hormone. The sperm penetration assay and other alternative tests can be used to evaluate the ability of sperm to penetrate an egg. Testicular biopsy may be warranted. Scrotal ultrasound can be used to examine the testes for presence of varicocele and identify abnormalities in the scrotum and spermatic cord. And in your textbook, box 5-2 lists factors that affect male fertility. Interventions. Some of the psychosocial interventions. Infertility is recognized as a major life stressor that can affect self-esteem, relations with the spouse, the family, friends, and careers. The couple facing infertility exhibit behaviors of the grieving process, such as those associated with other types of loss. The loss of one's genetic continuity with the generations to come can provoke decreased self-esteem, a sense of inadequacy as a woman or a man, and feelings of loss of control. Some non-medical interventions. Both men and women can benefit from healthy lifestyle changes that result in a BMI within the normal range, moderate daily exercise, and abstinence from alcohol, nicotine, and recreational drugs. Simple changes in lifestyle may be effective in the treatment of subfertile men. Using only water-soluble lubricants should be used during intercourse because many commonly used lubricants contain spermicides or have spermicidal properties. High scrotal temperatures can be caused by daily hot tub baths or saunas that keep the testes at temperatures too high for efficient spermatogenesis. Most herbal remedies have not been proven clinically to promote fertility or to be safe in early pregnancy and should be taken by the woman only as prescribed by a physician or nurse midwife who has expertise in the field of herbology. Relaxation, osteopathy, stress management, and nutritional and exercise counseling have been reported to increase pregnancy rates in some women. For medical treatments for infertility, see page 115. It lists the different infertility medications. The Center for Disease Control and Prevention defines assisted reproductive technology as fertility treatments in which both eggs and sperm are handled. In general, these treatments involve removing the eggs from the woman, fertilizing the eggs in the laboratory, and returning the embryos or embryo to the woman or surrogate. On the next slide, I have a chart that lists the different types of assistive reproductive therapies. You can read through this chart, but don't spend too much time. I don't expect you guys to be pros in IVF or assistive reproductive technologies. This is just an FYI so that you can see the different courses that infertile couples can take. Reproductive alternatives. If the couple does not conceive, they should be assessed regarding their desire to be referred for help, either with adoption, donor eggs or semen, surrogacy, or other reproductive alternatives. Now we're going to move on to the topic of contraception. Contraception is defined as the intentional prevention of pregnancy through sexual intercourse. Birth control is the device and/or practice used to decrease the risk of conceiving or bearing offspring. With the wide assortment of birth control options available, it is possible for a woman to use several different contraceptive methods at various stages throughout her fertile years. Those who use contraception can still be at risk for pregnancy if their choice of contraceptive method results in a method that is not used correctly. A multidisciplinary approach may help a woman choose and correctly use an appropriate contraceptive method. Nurses, nurse midwives, nurse practitioners, or other advanced practice nurses and physicians have the knowledge and expertise to help a woman make decisions about contraception that will satisfy her personal, social, cultural, and interpersonal needs. Factors to consider when prescribing birth control pills or birth control methods include reliability, the relative cost of the method. Does the method offer any protection from STIs? The individual's comfort level with the method, and the partner's willingness to use a particular birth control method. The safety of a method depends on a woman's medical history. There are some medical conditions that are contraindicated with the use of some hormonal contraception, and we'll talk about those a little bit later. This is a cute photo I found. It says the most effective birth control method known to man. And look, it's really cheap, man. It only costs a quarter. All right, now we're going to talk about different methods of contraception. First, we're going to talk about coitus interruptus, or the withdrawal method. It involves the male partner withdrawing his penis from the woman's vagina before he ejaculates. We know this is not 100% effective in preventing pregnancy because there is some sperm that can be released in the pre-ejaculate. Fertility awareness methods, otherwise known as FAMs. The contraception depends on identifying the beginning and end of the fertile period of the menstrual cycle. When women who want to use FAMs are educated about the menstrual cycle, 3 phases are identified. The first phase is the infertile phase before ovulation. The second phase is the fertile phase, about 5 to 7 days around the middle of the cycle, including several days before and during ovulation and the day after ovulation, because as I said before, the oocyte or the ovum or egg is only viable or fertile for 12 to 24 hours after ovulation. But we know that sperm can live inside the female reproductive tract for anywhere from 3 to 5 days. The third phase is the infertile phase, and that's the phase after ovulation. Natural family planning, also known as periodic abstinence. It provides contraception by using methods that rely on avoiding intercourse during fertile days. Natural family planning methods are the only methods of contraception acceptable to the Roman Catholic Church. Signs and symptoms of fertility awareness most commonly used with the abstinence are menstrual bleeding, cervical mucus, and basal body temperature. The calendar or rhythm method is based on the number of days in each cycle, counting from the first day of the menstrual cycle. The fertile period is determined after accurately recording the lengths of menstrual cycles for at least 6 months. Continuing with contraceptive methods, we also have the standard days method. The standard days method is essentially a modified form of the calendar rhythm method that has a fixed number of days of fertility for each cycle. A cycle beads necklace can be purchased as a concrete tool to track fertility or as a smartphone application, and many smartphones do have an ovulation calendar. The 2-day method. Further studies are needed to determine the efficacy of the 2-day algorithm in avoiding pregnancy and to assess its acceptability to users and providers. The basal body temperature method is the lowest body temperature of a healthy person. That defines the basal body temperature. Is taken immediately after waking and before getting out of bed. The basal body temp usually varies from 36.2 to 36.3 degrees Celsius during menses and for approximately 5 to 7 days afterwards. About or around the time of ovulation, a slight drop in temperature, approximately 0.5 degrees Celsius, may occur in some women, and then there are other women who may have no decrease in temperature at all. The cervical mucus ovulation detection method requires that the woman recognize and interpret the cyclic changes in the amount and consistency of cervical mucus that characterize her own unique pattern of changes at the time of ovulation. Many women don't like playing with their cervical mucus, so if the woman is not comfortable touching herself and seeing what her cervical mucus looks like, this may not be a good method for the person. The symptothermal method combines the basal body temperature and cervical mucus methods with awareness of secondary phase-related symptoms of menstrual cycle. The woman gains fertility awareness as she learns the psychologic and physiologic symptoms that mark the phases of her cycle. Secondary symptoms include increased libido. I like to tell the girls when he looks like Martin, well, let's think of a non-attractive person. You're dating someone that looks like, I guess, the Elephant Man from that old movie. But when it's time for ovulation, he starts looking like Billy D. Williams. That may be a good time to tell that you might be in that fertile period, because your libido increase and a gorilla starts looking like a fine, sexy man. Other symptoms include mid-cycle spotting, middle schmerz or crampy-like pains that happen before ovulation, pelvic fullness or tenderness, and vulvar fullness. The home predictor urine test for ovulation is a major addition to the natural family planning and fertility awareness methods to help women who want to plan the time of their pregnancies and for those who are trying to conceive. Breastfeeding, otherwise known as lactational amenorrhea method, it can be a highly effective temporary method of birth control. Lactation amenorrhea works best if the mother is exclusively breastfeeding and if she has not had a menstrual flow since birth and if the infant is under 6 months of age. This is not 100% guaranteed or sure, because sometimes the woman may never know when her fertility or her ovulation starts up again after pregnancy. But lactational amenorrhea is a method that can be used if the mom has not had a period since her pregnancy or the birth of the baby, and she is exclusively breastfeeding, and she's breastfeeding at normal intervals, every 3 hours, every 4 hours. It works best with those mothers that are breastfeeding. Here's the cycle beads that I talked about earlier. The red bead marks the first day of the menstrual cycle. White beads mark days that are likely to be fertile days. Therefore, unprotected intercourse should be avoided on those days. Brown beads are days when pregnancy is unlikely and unprotected intercourse is permitted. These are some examples of your ovulation predictor tests. All right, now we're going to move on to barrier methods of contraception. Barrier contraceptives have gained in popularity not only as a contraceptive method, but also as protection against the spread of STIs that we talked about today, such as HPV and herpes simplex virus. Spermicides such as Naloxone work by reducing the mobility of the sperm. Women with high-risk behaviors that increase their likelihood of contracting HIV and other STIs are advised to avoid the use of spermicidal products containing Naloxone, including lubricated condoms, diaphragms, and cervical caps to which Naloxone is added. The male condom is a thin, stretchable sheath that covers the penis before genital, oral, or anal contact and is removed when the penis is withdrawn from the partner's orifice after ejaculation. Condoms lubricated with Naloxone are not recommended for preventing STIs or HIV and do not increase protection against pregnancy. Latex condoms break down with oil-based lubricants, so it's important to tell your patients that when they're using condoms, they should use water-based lubricants or silicone lubricants. The diaphragm. The contraceptive diaphragm is a shallow dome-shaped latex or silicone device with a flexible rim that covers the cervix. The diaphragm is a mechanical barrier to the meeting of sperm with the ovum. By holding spermicide in place against the cervix for the 6 hours it takes to destroy the sperm, the diaphragm also provides a chemical barrier to pregnancy. Nursing considerations to consider when using a diaphragm. The woman using a diaphragm needs an annual gynecologic exam to assess the fit of her diaphragm. Her diaphragm may need to be refitted after a 20% weight loss or gain, a term birth, or a second trimester miscarriage, and after any type of abdominal or pelvic surgery. Disadvantages of the diaphragm include the reluctance of some women to insert and remove it, although it can be inserted up to 6 hours before intercourse. The cervical cap or FemCap is the only type of cervical cap available in the United States. It comes in 3 sizes and is made of silicone rubber. The cap fits snugly around the base of the cervix close to the junction of the cervix and vaginal fornices. It is recommended that the cap remain in place no less than 6 hours and no more than 48 hours at a time. It is left in place at least 6 hours after the last act of intercourse. The contraceptive vaginal sponge is a small, round polyurethane sponge that contains the Naloxone spermicide. The sponge must be moistened with water before it is inserted into the vagina to cover the cervix. It provides protection for up to 24 hours and for repeated instances of sexual intercourse. It should be left in place for at least 6 hours after the last act of intercourse. This image shows some of the different types of both hormonal and barrier methods. Here we have your birth control pills, your condoms. This is your female condom. This is a vaginal ring, your Depo-Provera, your implantable contraceptive methods, the Ortho-Evra patch. This is a picture of an IUD. This is a diaphragm, and this is a cervical cap. This is just some more pictures: female condom, male condom, diaphragm, the cervical cap, and this is what a vaginal sponge looks like. Female condom, fem cap, and the cervical sponge. These are just some different types of lubricants or contraceptive gel or spermicides. This is the preparation of the diaphragm. You notice that they're putting spermicide on the outside and inside the reservoir of the diaphragm. This is showing how you have to bend it to insert it into the vagina. This is showing the insertion. Now she's fitting it comfortably around the cervix. Just more pictures showing how it should be properly inserted. Actually, this looks like she's removing it. She's pulling it away from the cervix. This is showing a cervical cap that is correctly inserted. Another picture of the cervical cap. And then it's showing removal of the cervical cap. Now, before we start talking about the hormonal birth control, you have to actually know a little bit about informed consent. As healthcare workers, we are required to get informed consent whenever we put or order or place anyone on hormonal birth controls because of the severe side effects that can occur. So one of the acronyms that's used for informed consent when talking about hormonal birth control methods is the acronym BRAIDed. The B stands for benefits. So you have to give them information about advantages and success rates of the method they choose. R is risk. You have to give information about disadvantages and failure rates. A for alternatives, information about other available methods. I for inquiries, you want to give the person an opportunity to ask questions about the different types of contraception. D for decisions, give them the opportunity to decide or to change their mind. E, explanations or information about method and how it is used. And D, documentation, information given and the client's understanding of the teaching that you did. All right, now on to the hormonal methods. Many different hormonal contraception therapies using different delivery methods are available in the United States today. In your book, Table 5-3 describes the general classes of hormonal contraceptives. This is good for you to look at. You don't have to know every class. I'm not expecting you to be able to go out and give out birth control pills. So we'll start with the combined oral contraceptives. They work to suppress the action of the hypothalamus and anterior pituitary, leading to insufficient secretion of FSH, follicle stimulating hormone, and LH or luteinizing hormones. Therefore, the follicles do not mature and ovulation is inhibited. To maintain adequate hormone levels for contraception and enhance the compliance, combined oral contraceptives should be taken at the same time each day, taken exactly as directed. Combined oral contraceptions prevent ovulation and pregnancy cannot occur. The overall theoretic effectiveness rate of combined oral contraceptions is almost 100% if they are taken correctly. Some advantages, other advantages, because taking the pill does not relate directly to the sexual act. Combined oral contraceptive acceptability may be increased. Improvement in sexual response may occur once the possibility of pregnancy is not an issue. And for many women, it is convenient to know when to expect their next menstrual cycle. Contraindications for hormonal contraceptive or with combined estrogen and progesterone use include a history of thromboembolic disorders, so blood clots, cerebrovascular or coronary artery disease, breast cancer, estrogen dependent tumors because your combined oral contraceptives have both estrogen and progesterone in them, pregnancy, impaired liver function, liver tumor, lactation less than 6 weeks postpartum. If I have a mom who's breastfeeding and I give her contraception with estrogen, it can actually slow down her rate of milk production or completely stop it. So those moms, we don't give hormonal methods that contain estrogen. Also, smoking if older than 35 years of age, migraines with an aura, surgery with prolonged immobilization or any surgery on the legs, hypertension, usually severe hypertension, and diabetes of more than 20 years duration with vascular disease. One of the major disadvantages of using combined oral contraception is that it does not protect against STIs. Only your barrier methods, such as the condom and the female condom, protect against STIs. The effectiveness of your oral contraceptions can be decreased when the woman prescribed them takes certain classes of medication while they're on their birth control pills. Medications such as anticonvulsants, systemic antifungals, anti-tuberculosis tuberculosis drugs, and anti-HIV protease inhibitors. If you have a woman who's on birth control pill and she's taking these pills the groups that I listed, you may tell her that her birth control may be rendered ineffective and that she should use a backup method or find another method more suitable for the birth control. Other contraceptions that you see with hormones are the Ortho Evra patch, which I showed in a slide earlier, and the Nuva ring. This is a flow chart that shows how to take pills when you've missed pills. So let's say you miss one pill you want to take as soon as possible, and then take your next pill at a regular time. No backup method is needed. Let's say you get down here and you miss 3 or more pills, and you started your cycle of your pills on a Sunday. You want to take one pill every day until Sunday. Start new pack on Sunday. And then if you're a day one starter, throw away the rest of the pack. Start new pack on same day. And look it down here at the bottom. Use a backup method for 7 days if unprotected intercourse. You can also take emergency contraception as soon as possible. It used to be within 120 hours, but now we want you to take it within 72 hours. Some more hormonal methods. These are your progestin-only contraceptives. These types of contraception only have progesterone. They do not contain estrogens. Your progestin-only methods impair fertility by inhibiting ovulation, thickening and decreasing the amount of cervical mucus, thinning the endometrium, and altering cilia in the uterine tubes. Because progestin-only methods do not contain estrogen, they may be used in certain instances such as lactation when estrogen would not be recommended. Your oral progestins and your otherwise known as your mini pills. These are progestin-only pills. They are less effective than combined oral contraception because many pills contain such a low dose of progestin. They must be taken at the same time every day. If the pill is taken more than 3 hours late, a backup contraceptive method must be initiated. Your injectable progestin, such as Depo-Provera, which you see on the slide, is given subcutaneously or intramuscularly in the deltoid or the gluteus maximus muscle. It should be initiated during the first 5 days of the menstrual cycle and is administered every 11 to 13 weeks. Your implantable progestins, we know Norplant was taken off the market. Implanon is the only approved implantable contraceptive available today in the United States. Emergency contraception. Emergency contraception offers protection against pregnancy after intercourse occurs in instances such as broken condoms, sexual assault, dislodged cervical cap, disruption of use of any other method, or in any other case of unprotected intercourses. Methods that are available in the United States that could provide postcoital contraception include the Ella. It's a single 30 milligram pill containing an antiprogestin. The Plan B one step, Next Choice, or taking combined oral estrogen progesterone contraceptive pills. Or you can place a copper IUD, a copper intrauterine device, within 120 hours of intercourse. Plan B one step and Next Choice are approved by the FDA for over-the-counter sale to women ages 17 and older with proof of age. Before oral contraceptives are prescribed and periodically throughout hormone therapy, the woman is alerted to stop taking the pill and report immediately any of the following symptoms to the health care provider. The mnemonic that we use is ACHES, ACHES. The A stands for abdominal pain, which may indicate a problem with the liver or gallbladder. C for chest pain, which may indicate possible clot or problem within the lungs or heart. H, headaches, which may be caused by cardiovascular accident or hypertension. E for eye problems, which may indicate vascular accident or hypertension also. And S for severe leg pain, which may indicate a blood clot or some thromboembolic process. The intrauterine device or IUD. An intrauterine device is a small T-shaped device with bendable arms for insertion through the cervix into the uterine cavity. There are two FDA-approved IUDs, the Copper T made by Paragard. It is made of radiopaque polyethylene and fine solid copper and is approved for 10 years of use. The copper primarily serves as a spermicide and inflames the endometrium, preventing fertilization. There is no hormone in the copper T. The levonorgestrel intrauterine system, or Mirena, releases levonorgestrel from its vertical reservoir. It's effective for up to 5 years. It impairs sperm motility, irritates the lining of the uterus, and has some anovulatory effects. Disadvantages of IUD use include increased risk of pelvic inflammatory disease within the first 20 days after insertion, especially if infection is present at the time of insertion. There is also a slight risk of uterine perforation when you're inserting the IUD. In your textbook, box 5-11 talks about the signs of potential complications with using intrauterine devices. It would be a good thing to look at that box. When we're talking about signs of potential complications related to IUDs, we use the pneumonic pains, P for period late or abnormal spotting or bleeding, A for abdominal pain or pain with intercourse, I for infection exposure or abnormal vaginal discharge, N for not feeling well, fever or chills, S for missing strings, either they're shorter or longer. One thing when a woman uses an IUD, she has to be comfortable with touching her genitalia, because each month after your period or the woman's period goes off, they have to insert their fingers vaginally and check to make sure that their strings are in place. At the end of the IUD, there are two strings. We cut them as short as possible so that the partner won't complain of feeling the strings during intercourse. But the woman has to make sure that once a month after menses, she checks to make sure her strings are there. If her strings are not there, she needs to call her physician and be seen, because there could be the possibility that the IUD came out, especially if she has very heavy menstrual blood flow. These are what your IUDs look like. This is your Mirena, and this is your Copper T. Sterilization. Sterilization refers to surgical procedures intended to render the person infertile. Most procedures involve the occlusion of the passageways for the ova and sperm. For the woman, the oviducts or uterine tubes are occluded. For the man, the sperm ducts or the vas deferens are occluded. Only surgical removal of the ovaries, which is an oophorectomy, or uterus, which is a hysterectomy, or both, results in absolute sterility for the woman. All other sterilization procedures have a small but definite failure rate. So yes, I have had patients who've had tubal ligations who ended up pregnant. Female sterilization, also known as bilateral tubal ligation, may be done immediately after giving birth or within 24 to 48 hours after birth. It can be given at the time a woman is having an abortion, or as an interval procedure during any phase of the menstrual cycle. Half of all female sterilization procedures are performed immediately after pregnancy. It's just a lot easier to do. The uterus is in the abdominal cavity. It's easier to reach. It's a small incision, usually through the belly button, and usually we do it 1 day post delivery. Male sterilization or vasectomy is the sealing, tying, or cutting of a man's vas deferens so the sperm cannot travel from the testes to the penis. Vasectomy is the easiest and most commonly used operation for male sterilization. The surgery can be performed with local anesthesia on an outpatient basis. And when I did clinicals in the health department when I was working on my midwifery degree, we did them quite often in the health department. I think the urologist would always invite me to come look at him do the procedure. Little snip, little cut. They were usually out of the office in 15 minutes. Versus the woman having a tubal ligation where it's major surgery. Hint, hint, boys. All right, this slide shows the tubal ligation. Here you see the tubes have been cut and tied. You can cut them, you can clamp them, you can cauterize them. It all depends on the doctor's preference. And here is the in the male for the vasectomy where the vas deferens is severed and ligated so that sperm won't reach. This is showing how a tubal ligation is done through the umbilicus. More than likely this is a postpartum because the uterus is kind of up around the umbilicus after they deliver. Moving on to abortion. Induced abortion is the purposeful interruption of a pregnancy before 20 weeks of gestation. If the abortion is performed at the woman's request, the term elective abortion is usually used. If performed for reasons of maternal or fetal health or disease, the term therapeutic abortion applies. And in the case of miscarriage, we use spontaneous abortion, and you'll hear that in OB a lot. A lot of times we won't say it in front of the patients because you put abortion, it has a negative connotation. But if a woman miscarries, we term it a spontaneous abortion. Many factors contribute to a woman's decision to have an abortion. Indications include preservation of the life or health of the mother, genetic disorders of the fetus, rape or incest, and the pregnant woman's request. The control of birth, dealing as it does with human sexuality and the question of life and death, is one of the most emotional components of health care. It has been the most controversial social issue in the last half of the 20th century and continues to be so today. The incidence. In 2008 in the United States, there were approximately 6.5 million pregnancies, and approximately 19% of these pregnancies ended in termination. The Association of Women's Health Obstetric and Neonatal Nurses supports the nurse's right to choose whether to participate in abortion procedures in keeping with her or his personal, moral, ethical, or religious beliefs. AWON also advocates that nurses have a professional obligation to inform their employers at the time of employment of any attitudes and beliefs that may interfere with essential job functions. First trimester abortions. Methods for performing early elective abortions, usually less than 9 weeks, include surgical aspiration and medical methods using medications such as mifepristone, methotrexate, misoprostol. About 90% of abortions in the United States are performed during the first trimester, with more than 60% performed by 8 weeks after the last menstrual period. Second trimester abortions. Because the great majority of induced abortions in the United States occur in the first trimester, only about 10% are performed in the second trimester. Second trimester abortion is associated with more complications and costs than first trimester abortions. Dilation and evacuation accounts for almost all procedures performed in the United States. Emotional considerations. Because symptoms can vary among women who have had abortions, nurses must assess the woman for grief reactions and facilitate the grieving process through active listening and non-judgmental support and care. Again, we talked about the induced abortion is performed in the first trimester. It's the safest and it's less complex. Common complications associated with first trimester abortions include infection, retained products of conception, and excessive vaginal bleeding. If during the abortion all of the products of conception are not removed, the uterus cannot contract and clamp back down, so the mom will have problems with excessive bleeding and or hemorrhaging. All right, question. A physician prescribes Clomid for a woman experiencing infertility. She is very concerned about the risk of multiple birth. The nurse's most appropriate response is A. This is a legitimate concern. Would you like to discuss this further before your treatment begins? B. No one has ever had more than triplets with Clomid. C. Ovulation will be monitored with ultrasound, so this will not happen. And D. 10% is a very low risk, so you don't need to worry too much. If you answered A, you are correct. So the feedback for option A, the incidence of multiple pregnancies with the use of these medications is higher than 25%. The client's concern is legitimate and should be discussed so she can make an informed decision. Option B is incorrect. This statement is inaccurate and negates the client's concerns. Option C is incorrect. Ultrasound cannot ensure that a multiple pregnancy will not occur. And option D is incorrect. The percentage quoted in this statement is inaccurate. Furthermore, the client's concerns is discredited with a statement such as, "Don't worry." Okay, key points. Infertility is the inability to conceive and carry a fetus to term gestation. It affects about 10 to 15% of otherwise healthy adults. Infertility increases in women older than 35 years. In the United States, about 1/3 of infertility causes are related to female, 1/3 to male, 20% go unexplained. Common etiologic factors include decreased sperm production, ovulation disorders, tubal occlusion, and endometriosis. Some of the reproductive alternatives that we that are listed on that graph I gave in the PowerPoint. The IV, FET, gift, ZIFT, oocyte donation, embryo donation, surrogate motherhood and adoption. Contraceptive methods with various effectiveness rates, advantages, and disadvantages are available for people who don't want to get pregnant. Women and their partners should choose the contraceptive method best suited for them. Effective contraceptives are available through both prescription and non-prescription sources. Concurrent use of spermicides and latex condoms provides protection against STIs. Tubal ligations and vasectomies are permanent sterilization methods. Induced abortion performed in the first trimester is safer and less complex. The most common complication of induced abortion include infection, retained products of conception, and excessive vaginal bleeding. This concludes the audio lecture for Chapter 5, Infertility, Contraception, and Abortion. Thank you.